thank you for inviting me to your conference. I've known about ARNEC for a long, long time, since I worked in Bangladesh on their ECD programs. And I know you're a really strong, committed group, and I can see the attendance for 3 whole days at all of these sessions. It's really wonderful to see. So yes, my talk is called Approaches to Building Resilient Programs, Experiences from the Field. I've had experiences from the field in various programs, and I know most of you have had a lot of experience from the field. So this is great. All right, so there are many ingredients that are needed to make services strong and resilient enough to meet the challenges as they go to scale. And I'm going to focus my remarks on what I learned conducting implementation research in several low and middle income countries, especially on their parenting programs to raise children's mental development ahead of school. And at times I'm going to allude to similar evaluations that I've done in preschools, but I'll focus on parenting to start with. So I've put frontline workers, you can see on my first slide, I've put frontline workers front and center of this story. I'm referring here to health workers in particular, community health workers maybe, who are delivering the nurturing care messages to parents face to face. There are the other ingredients surrounding the workforce, and I'm going to talk about them throughout the talk here. So face to face. Does it have to be face-to-face? High dosage? Yes, it does. Whenever parents really don't know about the brain, and they don't know that children are ready to hear language at birth, and they don't know that children need to play in order to learn, especially when children are under 12 months of age, and they're not moving around seeking their own stimulation, they really depend on caregivers to provide that responsive stimulation to them. Stimulation is often not given in sufficient quantity or quality. And stimulation is like nutrition. It's got to be there in quantity and quality. Okay. There we go. So working with FHI 360 on their current research and learning program, this has been funded by the LEGO Foundation. The LEGO Foundation gave money to 4 groups who are delivering, 4 organizations delivering parenting programs in 4 different countries. And FHI 360 was asked to do independent research on the implementation of these programs, in some cases also their child and parent outcomes. So it's sort of a research and learning project with these 4 groups, and you can see the 4 of them up there. They're building and transferring to the government their parenting programs, and together we're supposed to do research and learn from the findings how to scale up parenting programs, what kind of challenges they meet. So you want them to be resilient and also effective. Effective in changing parenting practices and child outcomes, children's mental development. So you can see that these 4 programs are a little bit different. In this talk, I'm going to focus on Bhutan and Zambia. Okay, so Bhutan and Zambia. Bhutan has, well, they've actually spoken quite a bit at this conference, so I'm just repeating what many of you have already heard. They have 12 group sessions delivered to groups of parents by a health assistant who's kind of a professional, health professional. It expands, they have expanded, so they've scaled across the entire country, and they are in the process of transferring their program to the government now. Zambia, okay, so the Bhutan is delivered by the organization is Save the Children, but it's pretty soon moving into the government hands. The Zambia program is run by UNICEF. They offer 7 sessions, mostly home visits, of community volunteers. And yes, they have started in 2 different districts, and their expansion horizontally is within those 2 districts. So they started at the top with the government, and they're moving down towards the bottom. There's Rwanda and Serbia, and you can read what their programs are like. Some programs use professionals, like health assistants or nurses. Others use paraprofessionals, like community health workers, and many are using volunteers. They vary in the modality, they vary in the intensity, and they vary in their goal to scale. So here's an outline. Here's an outline of the FHI's implementation research. As I said, it's funded by the LEGO Foundation. And there are 5 research questions. The first one is the child and caregiver outcomes. We use the home inventory to look at caregiver outcomes, and we use now the GSED, the Global Scales for Early Development, to look at child outcomes. The second concerns community norms, and for that we use focus group discussions of fathers and mothers to ask them. Obviously, the big problem these days is male engagement, so a lot of it is about male engagement. The third concerns the workforce, and as I said, I consider this the linchpin. So those are our questions there. What are providers' understanding about play and stimulation? And how do the providers deliver the programs? What's the quality of delivery? Okay, so those are the 4 methods we're using to assess the workforce. We're doing observations of training. We're doing the, Okay, he's setting me up a little bit here. Thank you very much. Great. Okay, so the training observations is obviously very important. We do a phone survey with the workforce, asking them a lot of questions. We do in-depth interviews with a small number of the workforce. And we're also doing independent observations of 60 service deliveries. And this happens annually across 4 years. The fourth is the programmatic factors. So we talked to the resource team about this, Save the Children and UNICEF in the case of Bhutan and Zambia. And finally, the enabling environment, which concerns, this is interviews with government stakeholders concerning what are their feelings about the organization and how they're being included. Do they have a feeling of ownership? Are they actually seeing the evidence for effectiveness? What's being disseminated and how are they involved? Okay, so I want to start by talking about the top-down approach for governments. I'm going to start, in other words, with the resource team and the decisions they made at the beginning with the government to do, let's say, a top-down approach to scale. Now, top-down is what Zambia is doing, UNICEF is doing in Zambia. There's also the bottom-up approach, and I'll follow shortly with that. But in Zambia, they decided to work with the government, which UNICEF often does. This is very good. Get the policy framework going and the funding and so on, and then start moving down, training volunteers to deliver the 7 home visits for Care for Child Development. And the choice of volunteers often in Africa is due to budget limitations, which is fine. Many of them use volunteers. They should often receive a stipend. Many of them do, some of them don't. So the choice of 7 home visits by Care for Child Development was not exactly based on evidence. If you actually do a situation analysis to find out what do the volunteers, these community-based volunteers, what do they know about mental development? What do parents do with their children? You would often find that these community-based volunteers, community health workers, don't know much more than parents do about brain development, mental development. Is this gal making signs to me or to you? Okay, so they often don't know very much about brain development. They don't know more than the parents they're talking to. So if responsive stimulation is low, and then you need fairly intense contact. And the program may not be effective if you don't have a high enough dosage with them. Zambia also realized later that group sessions are more appreciated by caregivers than our home visits. And that's the case in many countries. There's some research on that that's very interesting. Okay, so the take-home message for governments from this research on top-down programs is that you have to first conduct a situation analysis to find out what does the workforce know about mental development, what do parents know. So it's interesting that this group called Frameworks often does that kind of research for you in the country, and there's a very interesting one from Kenya. So I'm working also with a group who's doing parenting in Kenya, and yes, they revealed that the workforce doesn't know much more than parents do about child development, which was very little. So you have to select a curriculum that suits that workforce and that suits those parents. So we had to use in Kenya, we had to use a very structured, prescriptive kind of curriculum with a manual that explicitly stated what sort of activities were to be done, what to do and say with parents and children. So as I say here, the second is to select a curriculum that suits the knowledge and practices of providers and parents, and to select a structured and prescriptive one if their knowledge is low. And the third is to select a modality. The usual ones are group sessions, home visits, maybe clinic visits. Most mothers prefer group sessions over home visits, but I know a lot of you do home visits. Clinic visits are really too irregular and opportunistic to have much value. They're kind of low touch. So the second one is to select a modality that suits your population. The fourth is the intensity. And as I said, in Kenya, we had to have 12 sessions to really get any kind of effect in changing parents' practices or children's mental development. So the fourth is the intensity that's needed to bring about the changes that you want. All right, I want to go into the second approach. The first approach was top-down, which is what they're doing in Zambia. They work with the government and sort of trickle down. The other approach is bottom-up, and the bottom-up approach starts usually with a small project within communities. This is kind of what Save the Children does generally. A lot of NGOs do it that way. They may use a similar workforce. They may use the government workforce, which is community health workers, let's say, but the resource team works with communities first to adapt an existing program, of which there are many. I don't think there's any need at this point to start from scratch. They deliver it over several months. They evaluate its effectiveness. Hi. I think you're supposed to signal to him, not to me, whether you can, if you can't hear, and then he'll come up and do something special here. Okay, so yeah, usually they assess its effectiveness early on and make changes if it's not effective, so that they can only after they've got everything ready do they start going to the government and say, okay, we've got a program here, we've got the right training for the workforce, we've got something that's effective in changing parenting practices, we've got the right curriculum, we've got the right dosage, and so on. So their problem is often that they fail to convince the government, even though they've got a really good program. Or the government goes with another organization that has something cheaper but less effective. So the take-home message for organizations, if you work this way, is to work closely with communities, find out what their parenting practices are, use the government workforce so that you've got an in with the government to start with, provide evidence of effectiveness, disseminate your effectiveness information widely to government stakeholders, and if necessary, start forming coalitions with other organizations who are doing parenting in that country so that you can all present something to the government. Okay, so which approach wins out? There are pros and cons to both. Yeah, for the top-down approach, the good side there is that they ensure government buy-in. They usually can ensure some policy development or starting on policy development early on, early efforts at getting funding for the program. It's well integrated into the system, usually the health system if it's parenting or the education system if it's preschool. And it can be multi-sectoral, bringing in Ministry of Health, Ministry of Education, Ministry of Development, Social Protection, and so on. But they often lack evidence of effectiveness. Not always, but this is common. And they often lack lower levels of acceptance. So these were two problems that were written up by Gabriella Buccini in a case study of the Brazil scale-up, Criança Feliz. You can read about it there, but it's fairly common. Bottom-up approach, the good side there is that they can ensure that their program is adapted to communities, adapted to the workforce. They've got good effectiveness data, but they struggle to get the government to adopt their program, and they struggle to get policy going and funding. So the most successful programs work both ends at once, simultaneously. Testing out a curriculum, working out the intensity, improving after each evaluation, while talking to the government champions and other government ministers to get them interested in adopting your program. A second ingredient of a resilient program is a workforce receiving supportive supervision. There's a lot of talk about supervision in a panel discussion I was in yesterday. Many programs have what you call administrative supervision, where people hand in written papers, written reports of who they visited and when. But supportive means that the supervisor monitors, observes the delivery of a program, gives the provider feedback, gets information from the provider as to what challenges they are encountering, and then mentors them. So at FHI, we've used a tool to observe and rate the quality of home or group sessions, and we give this feedback to the in-country resource team. And then we look for improvements during the next round of observations. Okay, a strong program needs to demonstrate accountability. So they need to deliver their program with quality. They need to effectively impact families. So over the years, we've perfected this measure of quality so that it correlates actually with changes in parenting programs. If the workforce gets high quality ratings, you're likely to see changes in parenting practices. Simply providing information is too light touch. You need techniques known to change behaviors and help caregivers adopt these responsive practices. These behavior change techniques, I have to tell you, are not a mystery. They've been studied for decades. So this is what we observed. We observed, did the delivery include asking how parents played at home since the last session? Did the provider, during the group session or home visit, introduce new play? Did they introduce responsive play and talk? Did they demonstrate new play to the parents and then give the parents an opportunity to practice with their child and then get coached on this new practice? Do they explain to the parents what are the benefits of all this extra stuff I'm teaching you? And do they solve problems? Help parents solve problems. So those are the features that are what, left? Okay. Those are the features that we are looking at. Here's the measure. You can just look at all of those items on the left-hand side, and somebody goes in and observes 60 different providers and rates them. 1, I didn't observe them asking about how have you played with your child, or I didn't observe how they did new play. Or 2, I observed, but it wasn't done well, it needs improvement. Or 3, it's very good. So if you want, you can look at the percent very good column And you will see round 1 and round 3. This is in Zambia. You can see that asking about what you did at home improved from 21% of the providers being very good to 68%. But on the other qualities, they don't do so well. They don't go up quite as much. Here's Bhutan, Save the Children program, round 1, and then 2 years later, round 2. And you can see how really across all of these, their percent of the providers who performed very well went up considerably. I want to talk about 2 of these qualities. One has to do with responsiveness. And this is just a little cartoon about what responsiveness is. Responsiveness means that you let your child initiate something. This child is just babbling away. And what's the father doing? He's looking with interest and listening. So that's his response, and possibly he will answer shortly afterwards. A lot of people are misunderstanding responsiveness, so I just decided to show this cartoon. Another issue is problem solving. Non-judgmentally encouraging parents to raise problems that they encounter when enacting the practice. So they say to parents, some of you found it difficult to play with your child in the way we talked about the last session, what happened. And of course, parents always come up with problems if you offer them an opportunity and don't just sweep it under the rug. So the common ones are, I'm too busy, I can't play with my child, I was sick, I have no money for toys, and so on. And so you handle those issues. Okay, so a resilient program seeks information using implementation data and then plans and acts to remediate the problem. And you can see we didn't see too much change in the Zambian program. Other issues, they were slow to translate the counseling cards. They didn't make revisions to the cards to help the providers or parents. No refresher training and no increase in in-person supervision. The Bhutanese program made a lot of changes between round 1 and round 2, revised the instructions to improve quality, had a refresher training, developed a monitoring tool themselves, and had somebody implement that. Okay, I was going to spend a little bit of time on this, but I won't much. This is the preschool quality measure, which likewise looks at quantity and quality of stimulation provided by adults, peers, playthings, and so on in the environment. It's called the Measure of Early Learning Environment Setting, the MELI. Focuses on a competency-based curriculum, lots of manipulatives for children, individual free expression, and stimulation that responds to the curiosity of children. And I just want to show you that World Vision came up with this dashboard using the MELI, using those items so that somebody could go in and observe, monitor the preschool, rate them on these MELI items, and come up with a simple sort of infographics dashboard so that everyone, including the preschool teacher, the supervisor, the folks back in the capital city, could see what was going on in terms of all of these items. This is the one they use found in Bangladesh. They're using it in many South Asian countries. Okay, so I wanted to talk about institutionalization within the system. This helps to, institutionalization allows you to scale up and also makes your program stable because institutions in the country are stable. So for example, they will have the medical faculty doing the training of the health assistants or the nurses or whoever. Institutionalizing it within the Ministry of Health with a set of duties for each of the job descriptions that are happening. And finally, I guess I would have to say that funding is another very important ingredient for resiliency. We all know that preschool and primary school countries get a lot of money from GPE, Global Partnership for Education, who gets their money from various granting agencies, right, like World Bank and UNICEF. And there, the Ministry of Education gets a lot of technical support, on how to provide materials for their preschools, conduct teacher training, develop a national policy, monitor output and outcomes, and so on. So funding is essential. And we ask, where is the funding for parenting? It's definitely not at the same level, which makes many of these programs, it puts them into jeopardy whenever they run into a stress test. And I guess my final slide is to test the resilience of a program. You just inject a stress test of whatever sort you want, which we should do every 4 or 5 years, and see how resilient our program is. Okay, we all went through one stress test when the pandemic came. These 4 programs were all a little bit delayed, but they resurrected everything at the end of the pandemic and shot back up beyond where they had been before. So that was one stress test. Another stress test is when you actually transfer it to the government, and maybe they say, oh, we don't have the funds to support it at the level that you were doing before. And you say, well, okay, we needed those funds to establish, but maybe not maintain it. And we want to reduce the workload of the workforce. We want to minimize. So yeah, you have to watch that you're not changing it so much that it's no longer effective. The stress test for the Criança Feliz in Brazil was that somebody went and did an effectiveness assessment and looked to see whether parenting practices were changing and children's mental development, and they found they weren't. Okay, so what do you do when you get that information? Yes, you have to go back. You go back right to the design. What was the curriculum? What was the intensity? What's the modality? And so on. So I do suggest that people do these stress tests intentionally on their own every 4 or 5 years and see, but also be prepared to make some changes. Thank you very much.